Good morning, everybody. My name is Emily Levitan. I am an associate professor of epidemiology here at UAB. I'm also a member of the Biostats Epidemiology and Research Design core for the CCTS, and I'm involved in some of the training and mentoring programs here. So it's really a pleasure to be here this morning. I'll be talking about epidemiologic study design. And this is a topic that is a little hard to present because this is what I've been doing for the past 19 years. And so, trying to give you a sense of what epidemiology is all about in, two-ish, a little under 2 hours is a bit of a challenge, but hopefully it'll give you at least a taste and then point you towards resources that will help you if you are maybe doing any sort of observational studies. One thing I will start with is to say that epidemiology is one sort of lens to do observational research. There are certainly others, people in health economics, health systems research, psychology, sociology. All of these fields use a lot of observational study design and study analysis techniques. And there's a lot of overlap. Unfortunately, there's not a lot of consistency in how we talk about these things. So there are a lot of very similar concepts across these different fields with slightly different words, which can lead to a little bit of confusion. Because I'm an epidemiologist and this is my training, I'll sort of give you the epidemiology view of things, but just to be aware that this is not simply the purview of epidemiology, and that there are other ways of describing it that are equally valid in other fields. Also, this is a small group, so please, if you have any questions, let me know, or any comments. So just give me a ping, or if you see anybody online who is trying to ping me, please do that as well. It's a little hard to see from here. So what we're going to talk about, correlation and causation, developing a testable hypothesis, designing an epidemiologic study, and epidemiology resources. So to start with, you'll hear people say a lot, correlation does not equal causation. Okay? So if you see an association, it doesn't necessarily imply cause and effect. So why not? But what else might be going on there?
Confounder.
So confounding is a big one, right? So, my sort of broad thing would be biases, right? That there's something else going on, and confounding is one of the major biases that we worry about as epidemiologists. But there's others. So confounding is sort of top on my list. There's also issues of measurement error, right? So are you actually capturing the thing that you want to be capturing? Selection bias, which I have an example of, and I'll show you. And then there's others. In the field, and again across fields, there are different ways of describing these, and I'm sort of in the big buckets of types of bias as opposed to all the different, but there are other specific biases that people use to fit underneath those buckets. The broadest definition of confounding is that people who are exposed are different than people who are not, in ways that are not necessarily directly related to their exposure. In other words, that something other than exposure is causing the risk to be different in exposed and unexposed groups. When we talk about confounding, we often use these sorts of diagrams. And these diagrams are both sort of a nice visual shorthand, but they're actually also Markov models. And so there's a lot of math behind these if you want to go that direction. But I think also, just as a visual, they can be helpful even without the math. So here, if we're thinking about the association between race, ethnicity, and obesity, so if this is our association of interest, age is going to be a confounder of this association, because the population distribution, so the sort of population structures are different across different race and ethnicity groups in the US. It's not a biological thing, it's more a demographic, sort of just the way the population is structured. And there's a relationship between age and obesity. So what happens is that if we ignore this difference in ages across racial and ethnic groups, you're going to see some proportion of the association between race, ethnicity, and obesity is actually going to be due to age and not race, ethnicity itself. And so this is a classic confounding. So our solution is that we can control for age, right? So I think you guys have already had David Redden's biostatistics talks, and there are a number of different statistical techniques that we can use to control for age. And that those techniques, what we're trying to do is get at, to parse out the race, ethnicity, and obesity assumption or association from everything else and get closer to cause and effect. As epidemiologists, we are trained not to really talk about cause and effect, but what we really care about is generally cause and effect. So here's another example, right? So if we think about fruit intake or fruit and vegetable intake and obesity as our study question, you see that there is an association between fruit and vegetable intake and obesity in observational studies. If you actually do a clinical trial and give people fruits and vegetables, it doesn't really do much in terms of their body weight. It can do other stuff. One of the issues there, right, is that some sort of propensity to be healthy is likely to lead people to both eat more fruits and vegetables and to have a lower body weight or a healthier body weight. Right, so some part of the association between fruit intake and obesity is due to being healthy, right? That there's just some characteristic of people that leads to both characteristics. The problem is, how do we measure health? Right, so age we can get a pretty good grasp on. Being healthy is a harder thing to try and capture. We will do things like look at, do you exercise? Do you do preventive health screenings, those sorts of things, but they're not really fully capturing that. So this is both an issue of confounding and actually an issue of measurement error here. So we're not able to capture the concept that we're really trying to make. Questions, thoughts about this? So just because you can put things in this sort of diagram where you have three characteristics and arrows going between them, you have to pay, doesn't mean it's necessarily confounded. You have to pay attention to the direction of the arrows. So if we're interested in the association between obesity and myocardial infarction, diabetes is not a confounder here, right? It's still going to be associated with your exposure, it's going to be associated with your outcome, it will change your effect estimate, so all those sorts of things. But it's not a confounder because it's actually on the causal pathway, right? That one of the ways that obesity causes heart disease is through diabetes. So I have this example to underscore that you really have to think about what do you know about the world, and you can't just use an automated method to select confounders because if you use some sort of stepwise selection procedure, it's going to pick up diabetes. But in this case, you could actually be adjusting away part of your association.
So if you've got a pathway that not much is known about, how do you approach that as to what you identify as confounders versus things that you want to include in them?
Right. So that is sort of the very big tricky question. So if you know a lot about the world, and these are pretty obvious examples, well-known examples. It's relatively easy to figure out which direction these arrows go. If you don't know, or there's not much in the literature, right? So you have to make your best guess. One of the nice things about these kinds of diagrams is it forces you to really think about what it is that you're assuming, because anytime you run any sort of statistical analysis or any sort of model, you're making a lot of assumptions, and what these models or what these sort of diagrams can help you do is say, okay, what assumptions am I making and am I comfortable with them? So what I would say there is you make your best guess, you run your model, and then you say, okay, I don't actually know exactly what's going on here, so you can do a sensitivity analysis and say, okay, under a different set of assumptions, what would this look like? This is something that we come across a lot when we're doing studies. So we'll have a bunch of characteristics measured at the same time. So sort of sticking with this theme, say we're measuring diet and we're measuring diabetes and hypertension. Well, so people with diabetes, one of the treatments is diet, right? And so people with diabetes are going to get dietary counseling, and hopefully, fingers crossed, they're going to make some changes in terms of what their diet looks like. So in that case, it's hard to say which direction the association between diet and diabetes is going to be going if you only have things that measure at a single point in time. So what we'll often do is say, okay, here are things that I'm sure are only confounders, and I'll run one model with those things, and then I'll add some things that might be either confounders or in the causal pathway, which as an epidemiologist I would call a mediator. It's called something slightly different in different fields.
In this case, if you were interested in the association between just diabetes and myocardial infarction, and say we didn't know a lot about diabetes, could obesity be considered a confounder?
Yes. So the way I've drawn this, if we're looking at the diabetes MI association, then obesity is a confounder.
But it's just if you're looking at obesity and MI, then diabetes is not confounding. Okay.
Correct. The other thing is, I've drawn these all with just 3 characteristics because it gets a little messy otherwise. But we're usually not dealing in a world where there's only one exposure, one outcome, and one confounder, right? So you can have a much more complicated diagram. It just then gets a little, the visual is not as useful. Other questions, comments? So another big issue that we deal with is selection bias. And this is a bias that occurs when being exposed versus not affects whether you even wind up in your study. One example is differential loss to follow-up. So if you're following a group of people and some of them you can leave your study, and they leave your study in ways that are related to their exposure, that can cause major problems. So one of the challenges, I think that electronic medical records and the use of electronic medical records is something that's very exciting in the field. We've not really been able to figure out the selection bias issue, particularly for institutions like UAB that are big tertiary care centers. So if we want to know, is rural residence associated with cardiovascular disease among patients with cancer, right? This is a potential reasonable question. We can say, okay, our study population is going to be patients treated at UAB for their initial cancer therapy. Now, if you think about that, right, the UAB Cancer Center is pulling from all over Alabama and surrounding states, right? So you've got a really broad catchment area. And we can say, okay, rural residents in CBD, this is like, oops. There we go. So, right, this is the relationship that we're interested in. The problem comes in is if we're using UAB medical records to capture CBD, we're going to get only those people with CBD who are treated at UAB. We're not going to get people who are treated in Jasper or Southern Alabama. And if you're talking about someone having a heart attack or a stroke, they're going to go to the closest reasonable facility, right? Unlike cancer therapy, where it's totally reasonable to say, okay, I'm going to drive 100 miles. You're not going to, if you can help it, you're not going to drive 100 miles to get your first heart attack, to get your first therapy for a heart attack. So what happens is we only see this piece, right? And we're sort of blind to treatment at other institutions. And it's really likely that people in rural areas are not going to be treated for their heart attack or their stroke here. So that's an issue of selection bias. And that's something that I think as a field we're really struggling with when we're trying to use this health system data. If you're at somewhere like Kaiser where they actually capture all this stuff, great. Or if you're in some of the Scandinavian countries where where you can actually see records across different institutions, it's a lot easier to do this kind of study than here, where you really have to think carefully about who's actually gonna wind up and who am I actually gonna be able to see. Questions about this? So I'd like to say that we have an answer. We don't yet, we're still working on it. I think, if we can get medical record exchanges, that's going to be probably the best way of doing this. And this is not this is not meant to be a knock on UAB or UAB's medical records. It's something that happens all over, and I actually just reviewed a paper that did this in Boston, and they have all the same issues. Okay, so another thing that is challenging, particularly as you are starting out, with research career and doing, and this particularly this type of observational research, is coming up with a testable hypothesis. So I would say 80% of the students, the first project they work with me, they come with this really big idea that is like 2 careers worth of work, right? Because they want to know some huge question. And to get to a testable hypothesis, which is basically like the hypothesis that you could address in, say, a paper, it takes a lot of narrowing down. Right? So if you're thinking about a paper, you're usually looking at 1, maybe 2 hypotheses. If you're looking at grant application, 3, 4, depending on the size, so the size and scope of your application. So my postdoc was looking at diet and heart failure. Right? So does diet affect heart failure? That's a huge thing, right? That's an enormous question, because we need to know what aspect of diet. Are we talking about foods and nutrients, dietary patterns? Are we talking about deficiencies, overload? Affect how? Are we going to prevent it? Are we going to slow the progression, prevent mortality in people who already have heart failure, reduce symptoms? What do we mean by it? Effect? And then in who? Right? Are we talking about older people, women, people with diabetes, mice? Right? So when I first started doing my lit review for the grant application I was working on, most of the diet and heart failure studies were actually done in Great Danes, who apparently have some sort of deficiency and have a lot of heart failure. So that is no longer the case now. There's a lot more out there, but at the time it was basically recommendations to reduce sodium and fluid intake based on best guess, and then all these Great Danes studies. So if we think about what makes for a good research question, there's a couple of different ways of structuring that idea. 2 that I think are pretty useful, and this is a reference that I think is nicely laid out, are for your idea is what's called the finer criteria, and for the framing is called the PICOT approach. So this paper is not the one that really came up with this, but I think it's a well-written paper that really nicely describes how to work through these. So FINER stands for feasible, interesting, novel, ethical, and relevant. Now, none of these are exactly cut and dry, right? So what's feasible for someone on a 1-year research fellowship is very different than someone who, say, is a full professor and has the rest of their career to work on a project. And so that will change both on sort of where you are in your career path, and then also who you are. So I work a lot with the REGARD study, which is this cohort study of 30,000 people. They've been followed since 2003. I do not have the logistical skills to pull this off, but someone else does. And so I couldn't have gotten the study off the ground, but other people can. And what the scope of what I can do now that I'm an associate professor and have a lot of connections here is very different from the scope of what I could do, as a postdoc or junior faculty member. Again, interesting. You don't want to set out on a study that is boring, right? Nobody really sort of starts that way, because if you're bored at the beginning, it's probably not going to get any more interesting. But what's interesting to one person is not necessarily interesting to another. So that's where I think talking to people about your ideas can be really, really helpful. There was a project that I was working on, and so I was working with this biostatistician, and the 2 of us came up with this really complicated 3-way interaction model that was going to talk about, it was going to answer questions about whether there were regional variations in how well hospitals followed guidelines, and whether there were guidelines important. And we took this to a collaborator who's also working on this, who's a cardiologist, and she was like, this is not interesting, right? You're talking about how well these hospitals were following guidelines 10 years ago. Nobody cares, right? So, then we went back to the drawing board and said, okay, yeah, we have this like really cool model that would answer a question that we think is interesting, but we're really more interested in the model. So like, let's refocus this. And so I think that it's really worth talking to a diverse group of people about your ideas to make sure that not only is it something that you find interesting, but it's something that the field will find interesting. Questions? Novel, right? So again, there's a lot of stuff out there. There's a lot of research out there. It's unlikely that you're going to come up with something that no one has ever thought of before, but you do want to make sure that there's something that you're adding, right? So that you can add, even if it's a question that's been asked before, is it a question that's been asked in the population you're interested in? Is there something that you're doing that you're able to measure that's new and better? There is value in replication, but you want to make sure that it's replication in a way that adds information and not just doing it again to do it again. Ethical, and again, this is not always an easy answer, right? So when we think about what is ethical research, there are some certain things that are easy answers, right? There are others where it's tricky, right? And it's a judgment call about whether the risks outweigh the benefits. So there's this study that I remember reading that was looking at air pollution and heart disease. And so what they've done is they've taken people with known heart disease, they have put them on a treadmill with a mask and they're piping diesel exhaust into the mask and having them exercise and then measuring their heart. Which to me, I was like, it's a really interesting study, and they had it under pretty tight medical control. But even so, I don't think that's some people looking good. But it's very interesting, and it does actually increase ischemia. The diesel exhaust. Very well documented. But in terms of it is a judgment call, right? And so that's something you need to work on with your mentors, with the IRB, with other, and to really think about what are the risks and what are the benefits of the knowledge that you're going to gain. Relevant, again, so that's another issue with my study where I was talking about guidelines 10 years ago, right? That has perhaps limited relevance in terms of what we're doing. So what we actually did with that study is we looked at what were the trends over time, and we showed that there are actually still huge differences in who gets statins by hospital characteristics. And that was stronger than any of the patient characteristics that we looked at post-MI. So that was a little frightening. But we wound up focusing on the most recent year of data, and that's a lot more relevant than, are different hospitals following guidelines better or worse. PICO approach. So this is really talking about what are the components that a testable hypothesis has to have. And these are, they're a little tortured to get to the PICO as an acronym, but patient population of interest, right? So who are you studying? The intervention or issue of interest, here I would pretty much call this exposure. What is your exposure that you're looking at? And then comparison, who are you comparing, right? So are you comparing a placebo group versus active drug treatment? Are you comparing two different treatments? For a lot of things like diet or air pollution, you're looking at, the range of exposures, right? Because nobody's unexposed. What is your outcome? And what is your time frame? And time frame is one that I think people are sometimes surprised about, that it has to be in there. And this is sort of a silly example, but makes the point. So is being infected with rabies associated with a higher risk of death? It's a silly question. Yes, of course it is. Except, if we think about what's the time scale we're looking at, right? So 100 years from now, highly unlikely that any of us in this room will still be alive, right? So whether or not we're infected with rabies, death rate will be 100%, right? Whereas, if someone gets infected with rabies, the 6-month risk is going to be hugely different, right? So that, particularly when you're looking at mortality, but for other outcomes as well, it's really important to specify, like, what is the time frame that you're interested in? Are you talking about 6 months, 30 days, 10 years? And those are potentially going to give you very different answers. Questions? So here's a better research question. So is intake of fatty fish associated with hospitalization for or death from heart failure among women? So that's got most of our pieces in it. And I can get a little more granular than that, right? So we talk about fatty fish intake is specifically because of the way that we measure diet. We're talking about salmon, herring, and mackerel. This is Sweden, so people eat herring and mackerel there in ways the US you really wouldn't. We have about 9 years of follow-up. We have middle-aged and older women, 2 counties in central Sweden, and we're only looking at women who did not have heart failure and looking at developing their first heart failure event. And these are the results we got. So you can see on the x-axis, you've got the frequency of consumption, right, from never to 3 or more times per week. And then on the y-axis, we've got hazard ratio. So these are ratio measures, like risk ratio kind of measures. And lower means protective, less than 1 means protective, greater than 1 means harmful. And in the scale here, right, so the hazard ratio could potentially go down to 0 or up to infinity. We have, so are you guys familiar with looking at graphs like this? Yeah, okay. So, you get, because never is our reference group, it's 1 and there's no sort of uncertainty around that. The lines represent the uncertainty for the other categories compared to never. The other thing to think about is, again, so correlation and causation, there's biological reason and biological plausibility to think that fatty fish intake might actually reduce the risk of heart failure. And we see an inverse trend up to 2 times per week. And then it looks like maybe it pops back up at 3 or more times per week. So a couple of things here. So one, Sweden is not very diverse, particularly these 2 counties, and these are all Swedish-born women. So this is almost everyone in this population is eating fatty fish once or twice per week. So that's where most of our data are. You have very few people who don't eat fatty fish. You have very few people who eat fatty fish more than 3 times per week. And the people who do are mostly eating pickled herring. And this is not something we captured in our the way we measured it, right? So, but what we know from the population here is that people eating a lot of fatty fish are mostly eating pickled herring, so that's a huge salt load. It's also bar food, and so these people are drinking a lot too. And in Sweden, even though this is middle-aged and older women, there is a lot. People who drink are often binge drinkers. So we tried to sort of model that out, but I think that that's probably what's going on in this highest group. So it's so again, thinking about, what might be your biases both in your design and your analysis, and then also in your interpretation. So.
Because in the study you have very few women who have never eaten or never eat, just like fatty fish. Mm-hmm. Potentially could you use like another cohort of like American women, because I'm sure it's easy to find a cohort of American women who never eat fish?
Yes. So
can you then compare against these Swedish women, or is that not possible?
Yes, you can. It gets complicated though, because the confounding there is, it's not necessarily better or worse, but it's different. Because in Sweden, everybody eats fatty fish. It's not a socioeconomic issue. In the US, eating fatty fish is a socioeconomic issue. And so, people, and so in the US, it's mostly salmon and then tuna, which is actually has some some fish oil in it, but not a ton. And that's most commonly seen in women who have substantial resources.
Yeah.
So you actually see much stronger associations between fish intake and heart failure in the US. And you don't see this sort of uptick at the end. So yes, I think that you can make those comparisons, but it gets a little, it's just doing the sort of numeric comparisons is probably not a good approach. You need to do sort of the numeric and then also think about what is the confounding structure and how might these be different and how might your exposure even be different.
Yeah, I was asking because just what you said, every time I see graphs like this that talk about fish intake, especially fatty fish intake, and any cardiovascular outcome, it's always like huge reduction in risk. Here,
Right.
this is not, I mean, it's impressive, but it's not anywhere near what we get. So that's why I was wondering.
Yeah, and I think that the differences in sort of the ways that confounding works in different populations probably does partially explain that. And that was why I was really interested in going to Sweden and doing this work because one, the diet patterns are really different, and two, there are much smaller associations between socioeconomic status and diet, and also a much narrower range of socioeconomic status in Sweden. So it gives you a different kind of view into what might be going on. Other comments or questions?
You mentioned about the triple herring and the beer intake. Did you all do like research before you implement the study to like include those confounders in the study, or how did you shape the method?
So that's a really good question. So, and one of the things about epidemiology is that often it's not that the study wasn't really designed to do this, right? So the PI that I was working with had designed the study, actually, it's called the Swedish Mammography Cohort because she was interested in breast cancer. And so she was really looking at risk factors for breast cancer. And so I came along, 10 years later and said, oh, maybe I can use this data to look at heart failure. So for me, I was kind of stuck with the data that we already had. If you're designing from scratch, then yes, you can, you do want to pick up all of the key factors that you think might be confounders and might be explaining this association. But then you have to wait for 10 years to sort of actually do the analysis. So it's, balancing act. Other comments or questions? Okay. So does anybody want to be a guinea pig? Want to talk about a project that they're working on? And this is sort of how if I'm talking to somebody as a bird consultation, the biostats epi research design, this is how I walk people through. Okay, so great. What's your outcome?
So I'm looking at incidence of diabetic ketoacidosis readmissions in patients with dementia.
Okay, so diabetes. Okay, so that's diabetic ketoacidosis readmissions. Okay. So that's your outcome. How are you measuring that?
We're looking at patients that live in the Birmingham area and looking at the EMR.
Okay. And are you using diagnosis codes? Or are you using medical record reviews? How are you capturing that?
We captured with diagnosis code.
Okay. And do you know how accurate those diagnosis codes are?
They are, it depends a little bit on the year and who codes it. So the ED tends to code a different code than the endo team. So once they get transferred to endo, it's pretty accurate.
Okay. So are you only picking the endo, or do people get treated?
They get
in
transferred to us eventually.
Okay. So,
Eventually.
so you're not having people treated and discharged from the ED? Okay. So what's your exposure?
Yeah, so there are really a couple different types of long-acting insulins. The most common is called Lantus, and it works for 24 hours. And then there are two newer types of long-acting insulin called Toujeo and Degludec. And anecdotally, a lot of us switch our high-risk patients over to those with the hope of changing this. So we're looking at Degludec and Toujeo versus Lantus.
Okay, so two different kinds of long-acting insulin, or different kinds of long-acting insulin. So those are, and so that captures both your exposure and your comparator group. And then you said people with type 1 diabetes living in the Birmingham area. And how do you enumerate that?
So they are going to be the age 13 to 18, treated between, pulled the records from 2012 through 2018.
Okay. And so these are all patients treated at Children's Hospital? And so did they have to be admitted, or could it be people treated outpatient?
They have to be admitted.
Okay, so these are people who have already had at least one admission. Okay. So that probably means it's a higher risk population than your sort of general patient population with type 1 diabetes. And then what's your time frame?
So we are trying to do, it's called a self-control case control series. So because these are higher risk patients, we don't want to just take those on Ecological and compare those to Lantus, because we know we put the high risk kids on those. So we're looking at the year that you were on Lantus versus the year you were switched over to the ultra long acting. And so it's a 2-year time period that could be any time between 2012 to 2018.
And your sort of in like your target date is the date that they got switched?
Yeah.
Okay. So what are the important confounders of this association? These are things that, and these have to be things that are strongly associated with your outcome and your exposure.
So age is huge. The higher risk, especially in the teenage years, we know these kids come more often. A history of DKA is also a risk factor, and that's one of the criteria to get enrolled. In terms of demographics, there's not a huge difference between men and women. Comorbidity is luckily it's kids, so there's not a ton. Health behavior is one thing that I would like to look at, but don't have a way to pull from the EMR is parental oversight. So those who have parents that supervise more tend to have fewer admissions.
And what about things like consistency of prescription drug coverage, costs, all of those things?
Yes. So about 70% of our kids are Medicaid. So the coverage is actually pretty decent. But that's certainly
so I would say, that's, like it sounds like you're well on your way to getting this project up and running. So you've got a lot of these questions already answered well. And so but those are the sorts of questions that if you come to, talk to an epidemiologist about your study, these are the sorts of questions that we want to know. And you don't necessarily have to come and talk to me once you already have those questions answered, right? Actually, it's more helpful probably earlier in the process as you're really narrowing down what exactly you want to do. But I think that, but those are the sorts of things that I would ask someone who was sitting across my desk, thinking about their study design. So once you think about, okay, what's your hypothesis, then you can move on to the study design. And so what kind of study are you doing? I don't actually have anything about, the sort of case-only designs that you're describing here, but those are another option. And so we want to ask about, is this a who and how many kind of question? Do we just want to know, like, what's going on in our population? This is a question about why. How frequent is your outcome? Can the exposure be measured after the outcome has already happened? Does prevalence tell you about incidence? How much time and money do you have? This is always a big one. And what's been done in the past, right? So there are some study designs that are a lot stronger than others. If it's the first time this question has been addressed, it makes sense to do like sort of the quickest, easiest thing. If there's a lot of data out there, you probably don't want to do a weaker study design. People have already done it. You're not going to add much. So if we think about surveillance, this surveillance is a systematic approach to determine how many people have a disease, so that's the prevalence, or how many people develop a disease, and that's the incidence. Honestly, as an academic epidemiologist, I don't really do much of this. This is more what epidemiologists in state and local health departments and the CDC do. So one example is this paper on the Zika outbreak on the island of Yap. So this was several years prior to the outbreak in the U.S. and in the Americas. But they were looking at antibody prevalence and then disease incidence. So one of the reasons that this paper wound up in the New England Journal is because they can really define their study population, right? So they've got a sample, they know that there are 1,276 households on the island of Yap. It's a small place. They're able to draw a sample of 200 of those households. They took blood samples and they interviewed the people living in those households about disease with symptoms similar to Zika. So what they found was that of their 557 people, 74% had antibody evidence of having been infected. 38% of the people with antibodies reported having symptoms of Zika, and 19% of people without antibodies have reported symptoms of Zika. So what does this tell you about Zika virus? So is everybody who's infected going to get sick? No, right? So you've got a lot of people who are, who were infected and where we have good evidence that they were infected, but don't report any symptoms. So that's one thing, right? You can see that it also spreads, right? So 74% of the population has it. That's a pretty infectious disease. What do you think about the 19% of antibody negative individuals reporting having symptoms? What do you think could explain that? Right, so they're common symptoms, right? They're not very specific. What else could be explained?
Very good.
Right, so we tend to think about, laboratory tests as being like a gold standard and being objective, but they're not always accurate, right? That you can have people who, for whatever reason, don't mount an IgM response, or these blood samples are being taken on an island and then collected. People are going door to door doing these blood samples, collected, packed, and shipped to Atlanta. Anything can happen sort of in that chain. That can, things can go wrong with the blood samples, and then once they get to Atlanta, things can go wrong there too. The other thing they did was they looked at the medical records of all of the healthcare facilities. So again, they could do this because there was one hospital and 4 medical centers. And they have a suspected disease definition, which was rash, arthritis or arthralgia, and conjunctivitis. So again, these are common symptoms. And then the confirmed disease was symptoms plus either antibodies or RNA. And what they found was 185 suspected cases. So these are people with symptoms. 49 of them, they were pretty sure this was Zika. 59, there was sort of equivocal evidence. 72, there was no testing done, and 5 people tested negative, right? So again, this tells you sort of who and how many, but also points out that this is a non-specific, the symptoms are non-specific and the tests are not always 100% accurate. So surveillance answers questions about how many and who, but it doesn't necessarily answer questions about why. And in this case, the why, we already knew the why. Like, they're testing for a particular virus, but they want to know sort of who and how many people get infected in a population. We can talk about ecological studies, and these are studies where we're looking at population groups, and we're looking at the correlation between the rates of the disease and the rates or degree of exposure within populations. And we're measuring both exposure and outcome on a population level. So this is one of the sort of most famous ones, particularly in cardiovascular epidemiology. This is a 7-country study. And what they have is on the x-axis, we've got percent of calories from saturated fatty acids, and on the y-axis, this is CHD deaths per 100. And this is more than 7 because several of the countries have more than one location they were doing. But what they've done is they've really gone and essentially gone to like the Department of Agriculture, which tracks how much food is being produced and how much food is being exported and imported. And they're looking at food disappearance data, right? So they're just looking at, on the population level, of all the calories that are presumably consumed in the population, what percentage of saturated fat. They can do this because agricultural departments track this data, right? And they track it pretty well. So you don't necessarily need to go to each individual and say, what did you eat? Here, they're really just going to like administrative data and saying, what kinds of food were being eaten or what kinds of food were disappearing. They call it food disappearance data because we don't actually know if it's going to people, to animals, in the trash, but that's where this data is coming from. And then the outcome data is coming from death certificates and vital statistics. What you can see here is that there's a strong correlation with a correlation of 0.8, right? So correlations go from -1 to +1. So 0.8 is really pretty strong between the percentage of calories in saturated fat on the population level and the death rates. And you've got a really wide range of saturated fat intake. So let's see, here we've got Greece here, right? So at this point, this was done in the 60s. So people were mostly eating olive oil as their fat intake. And then here we have Eastern Finland. And so in Eastern Finland, you're getting about 25% of calories from saturated fat. At that time, the standard lunch was a butter and cheese sandwich. So people are eating really high levels of saturated fat. And then you've got the range in between, right? And this, so if you look at the study, this is not the only data on the relationship between saturated fat and heart disease. If this was the only data, I'd be a little skeptical. But this was really the study that kind of launched all the more detailed research into cardiovascular disease and the relationship with saturated fatty acids. This is a nice study design, and then it can also often be done using existing data, right? So you look at data that's been collected for some other purpose, and you're not going to have to wait for 10 or 20 years to see, what happens to people over time. But there's this ecological fallacy that people having events might not actually be people exposed. So you've got a range of intake within each of these populations, and you don't know how that relates to their events. The other thing is that, you're not really dealing with confounding here at all. Questions about this? So this can be a strong study design when the exposure is by nature sort of regional and regionally determined. And it can also be a strong study design when you're really sort of doing the preliminary parts of your preliminary analysis on a question. With a cross-sectional study, you are now measuring individual level exposure, but you're measuring your exposure and your outcome at the same time. So you're assessing prevalent disease and prevalent exposure. So an example that I did a number of years ago was looking at unrecognized MIs. So you think about sort of classically people wind up in the ED with crushing chest pain, but it turns out that actually about 20% of MIs are not clinically recognized, which is sort of surprising. And so we were looking at people who had told us they had no history of heart disease, but when we looked at an electrocardiogram, they had a Q wave on their electrocardiogram. And what you can see is the associations, and they're not terribly surprising. You see that older people are more likely to have these unrecognized MIs, people who are smokers with diabetes, hypertension, and high blood pressure. We did it this way because it's relatively simple logistically, right? So this is a study within the regards population at baseline. So right when they're recruited, we collected a bunch of information on them and did an electrocardiogram on everybody. It's relatively simple logistically, right? We don't have to follow people up over time. We just have one cross section. It's relatively fast. The problem is going to be that the prevalence is going to be related to the incidence and the duration of the disease. And what I mean by that is to think about how you wound up in the regard study with an unrecognized MI. First, you had to have an MI that caused a Q wave, and there's a bunch of different risk factors for that. Your MI has to not be recognized. So something happened where either the person didn't know they had it, or didn't have symptoms, or they had symptoms and wrote them off and didn't get treated, or they had symptoms, got treated, and the medical system missed it, or they had symptoms, got treated, the medical system picked it up, and the person had no idea what happened, right? And so all of these things are possible, and probably it's what we're seeing in the regard study is probably some combination of all that stuff. Then you had to survive, right? So you had to survive long enough to say, yeah, I'll participate in your study. You had to be healthy enough to say, yeah, I'll participate in your study. And the Q wave had to not go away, right? So the Q waves can go away. So all these things had to happen, and all of these things are going to be related to whether or not you have prevalent MI when we picked you up. Does that make sense? Right, so what we're seeing might not actually, right, these associations might not actually be what you would see if you were following people up prospectively. The other issue is that your disease may change your exposure. In this case, probably having a Q wave on your, probably isn't going to change any of these exposures, right? But there are situations where it would. And so one of the examples, when I was in grad school, one of my friends was was very interested in lupus, right? So she was studying risk factors for lupus, and all these papers started coming out saying people with lupus have lower vitamin D, and therefore we should supplement vitamin D to prevent lupus. So what's the problem there?
Often they're supposed to avoid the sun.
Right, yeah. So people with lupus are generally sun sensitive, and so you get vitamin D from the sun, and so what you're seeing is likely largely that people with lupus are not going out in the sun, and so their vitamin D is lower, right? So there is an issue, and so my friend was getting like madder and madder, and there were probably 20 papers that came out in that year. So a stronger study design that avoids a lot of those issues is a cohort study. So there you identify your population at risk of the disease of interest. So if you're looking at incident disease, you would exclude anybody who already had the outcome of interest. And you would follow them up to see whether the exposed groups are more likely to develop the disease or to develop the disease more quickly than the unexposed groups. An example here, this was looking at a large population of men who were asked about their drinking habits in 1986. These are all men who were healthy at baseline. They did not have any heart disease. And then every 2 years, for 12 years, participants were sent questionnaires asking, have you had a heart attack? If not, if the questionnaire wasn't returned, researchers looked for death certificates. The trick with this study was that they only enrolled health professionals, and so they did this to save money because they thought that health professionals would be relatively accurate in telling you whether or not they had the disease of interest, as opposed to say the regards participants, where people tell us all sorts of things and we have to kind of read between the lines to guess, and then we have to go and get medical records. Here they assumed that if a doctor or a dentist told them that they had a MI, that they had actually had the MI. And so they're looking at rates of heart disease by alcohol drinking and what type of alcoholic beverage. So again, this is one of these sort of relative risk graphs where one is null, and you can see that for any type of alcohol intake, the more you drink, the lower the risk of MI. And this is pretty, so this is pretty consistent. There's been a lot of studies that looked at this. there's sort of some popular ideas that red wine is better because of whatever sorts of components.
I've always seen the diagram because I'm very interested. As a J curve, where up into about 6 drinks, it actually starts to go like skyrocket up.
Right. So a couple of things there, right? And that's probably, yeah, you probably are going to have some sort of uptick. So 50 grams of alcohol per day is like 4.5, 5 drinks. So probably more alcohol is bad. But in this study population, there's just people are either not entering who are very heavy drinkers or lying. And it's probably, again, a combination of the two, right? So these are, so getting people who are drinking, more than 6, 7 drinks a day, that's pretty uncommon in the population. And
well, I think the study that I saw, I think it was a Russian population. So
right.
There you go.
Yes, right. So that's right. So if you went to Russia, where it's a more normal thing to do, people are probably, you have more people doing that. You have more people who are admitting to doing that, and then joining studies. Yeah.
But I think they've even revised the guidelines now where it is a J, but they did it drinks per week, and they stratified males and females, and males can have, I don't remember what it is, 21 drinks or something a week, whereas females like 7. So I mean, 21 drinks, if this is 5 drinks a day, 7 days a week, I mean, I just don't understand. Is that the punchline of this slide? Is there's confounders in here we just don't know about?
Well, so part of it is potentially confounding. So again, thinking about what the confounding would be. Actually, here, and